Good afternoon, everybody. Thank you for listening. I'm discussing today GPS in pregnancy, what's new. Overview. We will go through introduction, epidemiology, colonization, infections, screening policies, indication of intrapartum prophylaxis, intrapartum antibiotic prophylaxis, what's new, recommendations, and conclusions. Introduction. Group B Streptococcus GBS Streptococcus agalactiae is a gram-positive coccus, frequently colonizes the human genitalia and gastrointestinal tracts, and less frequently the upper respiratory tract. In pregnant and postpartum women, GBS is a frequent cause of asymptomatic bacteriuria, urinary tract infection, upper genital tract infection. Epidemiology. GBS infections in pregnant women include urinary tract infection, intra-amniotic infection, and endometritis. Incidence: between 15 and 35% of pregnant women are colonized by GBS in the vagina and/or rectum. The incidence of neonatal GBS is 1 to 2 infants per 1,000 births. Overall GBS prevalence of 16.6% in South Africa, with incidence of neonatal GBS disease in Western Cape as 0.53 to 0.67 per 1,000 births. Invasive maternal infection with GBS is associated with pregnancy loss. Invasive is defined as isolation of GBS from blood or other usually sterile body site, excluding urine. Prior to widespread use of maternal intrapartum chemoprophylaxis, maternal colonization with the GBS conferred an increased risk of chorioamnitis and early postpartum infection. There is no clear association between maternal GBS colonization during pregnancy and preterm delivery, but GBS does cause third trimester stillbirths. Among the pregnancy outcome data were available, approximately one-half of the maternal GBS infections lead to fetal death, neonatal infections, neonatal death, or pregnancy loss. Colonization. Colonization of a pregnant woman by GBS is a major risk factor for early and late onset infant GBS infection. GBS colonization in the bowel, flora, and the genital tract of 20 to 40% of adults. Infections. Urinary tract infection. GBS is a frequent cause of asymptomatic bacteriuria, cystitis, and pyelonephritis during pregnancy. Asymptomatic bacteriuria is identified by screening urine cultures that are obtained during perinatal visits, so at least one screening culture should be obtained during early pregnancy. Meta-analysis of the impact of asymptomatic bacteriuria in pregnancy demonstrate an association between untreated asymptomatic bacteriuria with a progression of pyelonephritis and low birth weight. The risk of adverse outcome is decreased with the antibiotic treatment of asymptomatic bacteriuria in pregnancy. Cystitis. Cystitis is diagnosed by a positive GBS urine culture in the clinical setting of urinary symptoms like frequency, urgency, dysuria, but without fever. Pyelonephritis. Pyelonephritis during pregnancy is diagnosed by a positive urine culture in setting of urinary symptoms, renal tenderness with fever. In a series of 440 cases of pyelonephritis in pregnancy, GBS accounted for 10% of cases. Intra-amniotic infection is also called chorioamnitis, which is referred to the infection of amniotic fluid, membrane, placenta, and or umbilical cord, with the clinical manifestations like fever, uterine tenderness, and maternal and fetal tachycardia. Endometritis its colonization with the GBS significantly increases the risk of developing postpartum endometritis. In studies of endometritis, GBS has been identified, I think, as a single pathogen in 2 to 10% of cases, but more commonly a component of polymicrobial infection. Neonatal Group B streptococcal disease. Group B streptococcal infection in neonates and young infants is classified by age at onset. It's early onset, late onset, and late onset. Early onset GBS. Early onset GBS generally presents at or within 24 hours of birth, but can occur through day 6 after birth. Late onset GBS. Late onset GBS usually occurs at 4 to 5 weeks of age. It ranges 7 to 89 days. Late onset GBS, also called very late onset GBS or GBS beyond early infancy, occur in infants older than 3 months of age. Late onset GBS infection are most common in infants who are born before 28 weeks gestation or in children with history of immune deficiency. Screening policy and prevention. Identification of pregnancies at increased risk for early onset neonatal GBS. Early onset neonatal GBS infection in the newborn results from vertical transmission. Identify pregnancies at increased risk for vertical transmission by using a culture-based approach, universal screening, or the risk factor-based approach. Universal screening, the culture-based approach, its approach for prevention of early onset GBS involves performing routine antepartum GBS, vaginal and rectal culture in all pregnant women and administering intrapartum antibiotic prophylaxis to all colonized women. The risk factor-based approach involves identifying intrapartum women with the risk factors for early onset GBS disease in the neonate. But the problem with the risk factor-based approach is that many cases of early onset disease occur in infants of women who have no identifiable risk factors. Centers of Disease Control and Prevention guidelines find that performing lower vaginal and rectal screening cultures at 35 to 37 weeks of gestation and administration of antibiotic prophylaxis to GBS carriers were associated with a more than 50% reduction in early onset GBS disease compared with the risk factor based approach. In fact, almost 1 in 5 culture positive women did not have a risk factor for early onset neonatal infection and would not have received intrapartum antibiotic prophylaxis. Major guidelines. According to American College Guidelines, universal culture-based screening strategy to identifying candidates for GBS intrapartum antibiotic prophylaxis was demonstrated to be superior to risk-based screening protocols for prevention of GBS early onset disease. The Center of Disease Control first recommended universal antepartum culture-based screening of all pregnant women and continues to be the standard. Regardless of planned mode of birth, All pregnant women should undergo antepartum screening for GBS at 36 to 37 weeks of gestation, unless intrapartum antibiotic prophylaxis for GBS is indicated because of GBS bacteriuria during the pregnancy or because of a history of a previous GBS infected newborn. Intrapartum antibiotic prophylaxis according to American College Guideline. Intrapartum antibiotic prophylaxis to reduce the risk of GBS early onset disease is based on two approaches. One is to decreasing the incidence of neonatal GBS colonization, which requires adequate maternal drug levels. Two, reducing the risk of neonatal sepsis, which is requiring adequate antibiotic level in the fetus and newborn. These therapeutic goals are considered when developing recommendations regarding drug choice dose for the intrapartum GBS prophylaxis. Indication of intrapartum antibiotic prophylaxis according to American College Guideline. We have intrapartum GBS prophylaxis indicated and intrapartum GBS prophylaxis not indicated. So indicated will divide it to maternal history, current pregnancy and intrapartum. Maternal history, previous neonate with invasive GBS disease. Current pregnancy, positive GBS culture obtained at 36 weeks of gestation or more during current pregnancy, unless the plan of delivery with Caesar or cesarean section. GBS bacteriuria during any trimester of the current pregnancy. Intrapartum indication, unknown GBS status at the onset of labor, whatever that the cause, and any of the following. Birth at less than 37 weeks of gestation, amniotic membrane rupture more than 18 hours, intrapartum fever of 38 and more, or intrapartum NAT result positive for GBS. NAT test we'll talk about later. It's a rapid intrapartum test. Intrapartum NAT result negative, but risk factors developed like labor before 37 weeks of gestation, amniotic fluid rupture, membrane rupture, and more than 18 hours, and intrapartum fever of 38 or more. Known GBS positive status in a previous pregnancy. Intrapartum GBS prophylaxis not indicated. Colonization with the GBS during a previous pregnancy, unless colonization status in current pregnancy is unknown at onset of labor. Negative vaginal rectal GBS culture obtained at 36 weeks of gestation or more during the current pregnancy. Caesarean birth performed before onset of labor on a woman with intact membrane regardless of GBS colonization status and gestational age. Negative vaginal rectal GBS culture obtained at 36 weeks of gestation or more during the current pregnancy regardless intrapartum risk factors. Unknown GBS status at the onset of labor, NAT result negative, and no intrapartum risk factor present. Intrapartum antibiotic prophylaxis regime according to American College Guideline, we divided to not allergic to penicillin and allergic to penicillin. If the patient not allergic to penicillin, so the penicillin G 5 million, we give it 5 million units IV as a loading dose, and then 2.5 to 3 million units every IV every 4 hours until delivery. As alternative medication, it's ampicillin. We give 2 gram IV loading dose and then 1 gram every 4 hours until delivery. This regime is used also here in South Africa, and also in the Royal College guideline they use this regime for intrapartum antibiotic prophylaxis. Patients allergic to penicillin usually they divide to low risk and high risk and unknown risk, and according for each one that we have alternative medication. Low risk they give cefalozolin 2 gram IV as a loading dose, and then followed by 1 gram IV every 8 hours until delivery, and the rest you can see here the regime. Guidelines from Royal College and UK National Screening Committee does not recommend testing all pregnant women for the presence of GPS using vaginal and rectal swab. NICE guidelines does not currently recommend selective testing for women considered to be at increased risk of GPS. Indication of intrapartum antibiotic prophylaxis according to Royal College guideline have previously had a baby with clinical GPS infection, have had GPS bacteriuria during their current pregnancy. South Africa guidelines we use risk factor based approach prevention policy with intrapartum antibiotic prophylaxis. Maternal screening for GPS recto-vaginal colonization during pregnancy in South Africa is still not routinely performed in public health facilities. Antepartum screening test. Standard is culture. Culture is time consuming. It needs at least 18 to 48 hours to get the result, and it's quite cost effective. Molecular diagnostic techniques such as PCR. PCR offers a good alternative to culture with 100% sensitivity and specificity. The other test is nucleic acid amplification testing methods. It's NAT for GPS detection. A nucleic acid amplification testing for GPS detection also can use it for intrapartum management as a rapid test performed at the time of presentation of labor. NAT-based testing offers a reasonable and potentially more sensitive alternative to culture for intrapartum screening, but however does not isolate the organism as a culture, therefore does not allow for antibiotic susceptibility testing. The last test is the expert GBS test. The expert GBS test is a rapid polymerase chain test to detect GBS colonization in pregnant women by using vaginal and rectal swabs. One randomized trial reported a sensitivity of 89% and a reduction in intrapartum antibiotic prophylaxis. The expert GPS test could be used to identify GPS colonization at the onset of labor as an adjunct to the risk factor-based approach, and could potentially reduce the unnecessary use of intrapartum antibiotic prophylaxis. The expert GPS test is run on the GeneXpert molecular diagnostic system, and each test is highly costly. What's new in GPS in pregnancy? According to American College guidance, the optimal window for antenatal GPS screening has been changed to 36 plus 0 days to 37 plus 6 days weeks gestation. Women who present at more than 37 weeks gestation with unknown status should be administered GPS intrapartum antibiotic prophylaxis if risk factors develop, Risk factors like rupture of membrane more than 18 hours or intrapartum temperature of 38 or more. Women who present in labor at 37 weeks plus 0 date of gestation or more with unknown culture status in the current pregnancy but with known positive GPS colonization in a prior pregnancy are candidates for intrapartum antibiotic prophylaxis. Recommendations regarding management and treatment of women with a penicillin allergy. Consideration of penicillin allergy testing for all patients with a history of penicillin allergy. Intravenous penicillin remains the agent of choice for intrapartum prophylaxis with intravenous ampicillin as an acceptable alternative. Vaccine. Vaccinating pregnant women is an alternative preventive strategy. A maternal GPS polysaccharide protein conjugate vaccine has completed phase 2 trials in South Africa and Malawi, have demonstrated safety as well as efficient transplacental transfer of vaccine-specific antibodies. Vaccine is covering 5 of 10 possible GPS serotypes, would cover an estimated 96 of early onset GPS cases in the UK. No clear effect of vaccination on colonization was observed in the 2016 pregnancy trial with the trivalent conjugate vaccine. Vaccination currently is more cost-effective than antepartum prophylaxis, antibiotic prophylaxis, and screening strategies. The role of progesterone in decreasing and prevention of GBS colonization. Vaginal progesterone is associated with decreased group B Streptococcus colonization at term. A retrospective cohort study done in USA in 2018 suggests that vaginal progesterone is associated with decreased prevalence rectovaginal GPS colonization at term. The biological mechanism for decreased GPS colonization in women using intravaginal progesterone suppositories is unclear. However, it's likely related to combination of factors which may include changes in vaginal pH or alteration in host susceptibility and immune responses to infection. Recommendations and conclusions. Targeted intravenous intrapartum antibiotic prophylaxis has demonstrated efficacy and prevention of GPS early onset disease in neonates born to women with positive antepartum GPS cultures. If the perinatal GPS culture result is unknown when labor starts, intrapartum antibiotic prophylaxis is indicated for women who have risk factors for GBS early onset disease. Intravenous penicillin remains the agent of choice for intrapartum prophylaxis with intravenous ampicillin as an acceptable alternative. Intrapartum antibiotic prophylaxis is recommended for women in confirmed preterm labor without known GPS colonization. These are my references. Thank you for listening.